anyone has ever. So today, I entitled this Disappearing Spoon, Disappearing Cancer. So hopefully that was intriguing for you guys to come. Thank you for everyone who's here in person. It is just great to be back in person. I think this is like my first in-person presentation in like 3 years. And thank you for people who are joining online. I know we all have very busy schedules, so it's great for people to join us virtually. This is my disclosure. IQAI is actually giving us grant support with running a clinical trial. So today, I'm really to cover 3 areas. We're to talk about glioblastoma, just to make sure everyone has a good background and understanding of that. We're then to talk about iron in that role in cancer. And then I'm going to end with gallium multilate, which has become my project along with many of my colleagues. So as an outline, it starts to seem like I'm covering 3 very different topics. So we're going to talk about glioblastoma. We're then to dive into some chemistry and then end with gallium. And I have to say, and just preface this, that as we go through this talk, it may seem like things are unrelated, but I promise you, they all do come together. And it comes together with something that I call gamma. Now, I don't know if we have any like wine enthusiasts out there and if gamma means anything to you, but anyone who has any love or passion of wine will maybe start to think of this when you hear gamma. Gamma is a grape that is turned into a beautiful wine. I would love to talk about wine for the next hour, but I don't think that's my career. So maybe I'll throw a little bit of tips in there, here and there, but that is not the gamma I'm referring to. So glioblastoma. I've done many talks in glioblastoma, and I always kind of reflect back. I take a week of my clinic, and this is actually reflective of 1 week of my clinic of all the glioblastoma patients that I saw. And I think that if you look at these films, you can really appreciate what this disease is and some of the challenges. So the majority of glioblastoma are a solitary mass. Hopefully, maybe we can't see my cursor. I don't see my cursor, but these are usually heterogeneously enhancing. They're usually solid mass. Sometimes though, if you look in that lower left-hand corner, there's not a lot of contrast enhancement, but it still is a glioblastoma. Don't let that fool you. That patient actually did particularly poorly. So the lack of contrast doesn't correlate with aggressiveness necessarily. Sometimes they can be multifocal, so that the image in the lower right-hand corner, that looks almost like brain metastases, but that is actually a multifocal glioblastoma. And then in the upper right center there, we actually have a patient who can't have MRIs. So it wasn't that long ago that we could only follow patients with CT scans. This patient had a clip that they were not able to have MRIs. And so that's what a glioblastoma would look like on CT. So the diagnosis of glioblastoma actually goes back to the 1920s when Bailey and Cushing came up with this histologic kind of schema. And this was the first publication that actually classified astrocytomas and glial tumors. And right in the center there, you have glioblastoma. And if you look around that flow diagram, you'll see other things that look familiar, like ependymomas and oligodendrogliomas, medulloblastomas. Not much has really changed in almost 100 years until recently. The importance, or excuse me, the hallmark features of glioblastoma are really threefold. So when we look under the microscope, if we see 2 out of the 3, if we see mitoses, if we see endothelial proliferation, if we see pseudopalisading necrosis, that gives us the histologic diagnosis of glioblastoma. And the importance of histology is that it actually predicts prognosis. So a glioblastoma is a grade 4. Those patients are not going to do as well as the grade 2 astrocytoma. The other thing that this graph shows you is that oligodendroglioma patients do better than the astrocytoma patients. But these are largely still incurable diseases. So keep in mind a grade 2 is not benign. It is low grade, and grade 3 and grade 4 is considered malignant. The standard treatment approach, just to review briefly, is what we call the STOOP protocol. Patients get radiation with temozolomide. And what this showed, and this was published in 2005, is this showed that patients who did chemotherapy with the radiation actually had improvement in progression-free survival as well as overall survival. Now, that improvement was only 3 months, but that was exciting to us. Like, we had a drug, we had chemotherapy that demonstrated prospectively that we could improve survival. The other thing to highlight is that the 2-year survival rate, you can see that there is a subset of patients that actually seem to derive a little bit more benefit because that 2-year survival rate more than doubled. The other FDA-approved treatment modality for the newly diagnosed glioblastoma population is based on the EF14 trial. And this is using tumor treatment fields, also known as Optune, which I've previously discussed here. Just to highlight, this is a picture of patients. All these patients are wearing Optune. It's a device that patients wear that deliver electric fields. Patients have to wear it 18 hours a day. Very well tolerated. This is the latest generation. The battery is about 3 pounds. You can see there on the bottom, the arrays, they now are Band-Aid colored, which seems to be a little bit more socially acceptable to patients. What this trial demonstrated, though, is it also improved progression-free survival as well as overall survival. And if you look at that overall survival, we're starting to get to pushing 2 years. And keep in mind that number is actually from randomization, which took place after radiation. And so you have this 2 months after surgery and radiation. And so we really start pushing that number close to 24 months. But that's really about it. That's how little we've really gained in the past 20 years. So standard of care is maximal safe resection, radiation with temozolomide, followed by maintenance temozolomide, plus tumor treatment fields. Some patients choose not to do tumor treatment fields. So that's why I have the plus minus there. At the time of recurrence, there is no standard of care. There's been no study that has been prospectively done that has demonstrated survival benefit. So here we often turn to redo surgery. We have, just a fantastic neurosurgical team with great expertise. So we have a lot of comfort with sending our patients back to surgery. The latest addition to the surgical world is LIT therapy, which is laser interstitial thermal ablation, which also has a role. Chemotherapy-wise, we often turn to CCNU, BCNU. Bevacizumab is a common drug we use, but it does not improve survival. So we try to combine it with other chemo agents, sometimes carboplatin. The other thing that we will often do is reirradiation. And this is also unique to our institution. There's a technique called pulse low dose radiation that has demonstrated, retrospectively, kind of compared to historical controls, that patients do have improved outcome and that it's relatively safe. So I always like to throw in cases. I think, cases really resonate with us. It's the real world that we walk in. And so let's just kind of take a look at a few cases. So 59-year-old new onset seizure, has a large left temporal heterogeneously enhancing mass. He undergoes surgery. It's a glioblastoma. He undergoes standard of care, followed by a CCNU and bevacizumab at recurrence. And he passes away at 20 months. So pretty standard, typical kind of course for a glioblastoma patient. This is another patient. This is a lady who also has a left temporal lobe mass, who presents with some mood changes. And she undergoes also the standard treatment. She completes 12 cycles of maintenance temozolomide. And this is her scan after treatment. She has no evidence of residual contrast enhancement. The big difference here, though, is that there is 8 years that separate these two scans, which means that she's still alive. And so what's different between these two? They're both about the same age. One is a male, one's a female, but there really hasn't been any gender differences in outcomes with glioblastoma. Both were histologically, confirmed to have the hallmark features. So this gets into molecular markers. And this was published shortly after the STOOP protocol came out in 2005. And it showed MGMT, which is one of our critical markers in terms of prognosis. In patients who are MGMT methylated, those patients have improved survival on the order of 18 months. The other marker that came shortly thereafter is IDH. In IDH status, if you are IDH mutated, you start to, your median survival is beyond 30 months. And these are histological glioblastoma. These aren't grade 2s or grade 3s. Those are completely out of this analysis. So when we go back to our patients and we look at these molecular markers, the first patient actually was IDH wild type, MGMT is not methylated, versus our lady was IDH mutant and her MGMT is methylated. So things are starting to make sense. And in fact, the most recent WHO classification actually has come up with what we call this integrated diagnosis. And so the first patient is glioblastoma IDH wild type versus the second patient. Because that IDH is mutant and because it has such a different prognosis, they do not want us calling this a glioblastoma. We actually call this a WHO grade 4 astrocytoma IDH mutant, really trying to separate these two populations. Now, for case 2, this lady still has quite a remarkable outcome. 8 years is still not the norm with having those markers, but it starts to make some sense for those, when we see these patients who break the rules, it's not just luck, there's actually some science behind it. One more case I want to present is a 57-year-old gentleman, new onset seizure. He is found to have a non-enhancing right frontal lobe mass. He undergoes a gross total resection, and histologically, this is a grade 2 astrocytoma. So it's like hypercellular, but doesn't have pseudopalisating necrosis or endothelial proliferation. So he has a gross total, and he kind of comes to us and is like, well, now what? Gross total resection, grade 2. Sometimes you can observe these. He says, am I cured? Am I to live? What's my outcome to be? And because of his age, we actually elected to treat him. Age does predict to some degree outcomes. So he actually underwent radiation temozolomide, and after 9 cycles of adjuvant temozolomide, he actually recurs. So what's going on here? This is a low-grade histology. Median survival for a grade 2 is actually 5 years. So why is he recurring within 1 year of diagnosis? This gets into this other paper that was published in New England Journal of Medicine, where they're looking at all these other markers. And this is quite apparent. You can see that there's one particular subgroup that behaves very differently. And these, I have to emphasize as well, these are all grade 2 and grade 3 histology. None of these are glioblastoma, but if you look at the TERT mutation, that curve and that median survival is starting to look like that of a grade 4 astrocytoma. So the WHO classification has come out and said, you know what, if you are histologically a grade 2 astrocytoma, but if you have TERT mutation, or if you have a gain of 7 or loss of 10, or if you have this EGR amplification, we are going to give you an integrated diagnosis of diffuse astrocytoma, IDH wild type, with molecular features of glioblastoma. And that's really to reflect that median survival that is starting to be closer to 2 years. And these are actually a grade 4. So in summary, glioblastoma remains an aggressive, incurable malignancy. Despite tons of research and tons of clinical trials, we really have not seen any significant changes on overall survival. And this molecular classification is becoming really important at predicting prognosis and is starting to guide treatment and will ultimately lead into clinical trial eligibility. All right, shifting gears a little bit. Chemistry. Most of us in this room have taken chemistry at some point of our education. Some have chosen to remove it from the brain and completely forget about it. And I am saying we need to flash back just a little bit. So I'm going to give you hopefully just a little refresher because we all truly know this. So the periodic table, this really dates back to Dmitry Mendeleev. He was a Russian chemist in the mid to late 1800s. And he took the 70 known elements at that time, and he found if he arranged them by atomic weight, there was sort of this pattern or this periodicity that fell into these nice kind of rows and columns. And he actually published this. I think it was around 1870. And he said, you know, I have these elements. There's some holes in this periodic table that I think there's elements that exist that we just don't know about. And his scientific colleagues kind of looked at him and was like, no, we know everything there is about science. Like, how can you tell me that there is something that we don't know yet? So this periodic table actually really didn't get any respect within the scientific community. It would take 5 years before the French identified a new heavy element called gallium. So gallium, which has become near and dear to my heart, was also the first hole to be filled in Mendelev's periodic table. Shortly thereafter, there was scandium and germanium that filled in those 3 spots. And suddenly his colleagues are like, oh, maybe you're onto something. So over the next 40 years, this periodic table evolved and really has become the backbone to chemistry to this day. Now, this is probably the periodic table, maybe. There is definitely a periodic there. This is the periodic table that is probably a little bit more familiar to all of you. So to refresh, 2 really important things we can learn from the periodic table. The first is that anything that is in a row has similar physical properties, and anything that is in a column has similar reactive properties, meaning that any of those elements in that column, if they participate in a reaction, are to be, you can almost not interchange them, but they're to have similar reactive properties. And this is to come back to some points I'm going to make a little bit later. Iron. Iron is probably one of the most important elements in the human body. Iron is essential for all cellular processes. It is important for metabolism. It's important for cellular growth. Iron has this ability to switch and gain and lose electrons between the 2+ and 3+ state. And it's that ability that allows it to fuel all these processes. But that very same principle also allows it to create free radicals, which are harmful. So while iron is important, it also can be detrimental. Looking at iron a little bit more closely as a refresher, iron binds to transferrin, which then is incorporated into the cell through the transferrin receptor. And cells don't like iron just kind of floating around. They actually will create these iron pools, which I wish my pointer worked, but you can see an iron pool there. It also binds to ribonucleotide reductase. It's taken into the mitochondria. And so for every process where there's an influx, you also have to have an efflux pump. And so that is with ferropoietin. And so to simplify this, in the normal cells, here's a normal cell. We have an import, we have an export, we have an iron pool. What scientists have shown over the years in many different types of malignancy, this is an example using breast cancer, is that cancer will alter these pumps. So they'll increase the number of importers, increase the number of transferrin receptors, and decrease the amount of exporters. And so as a result, you get this increase in iron pool that then can fuel all these cellular processes that are required for cell growth and replication. So the question is, do we see the same thing in glioblastoma? And I guess I wouldn't be here talking about iron if we didn't. And so scientists have shown that glioblastoma has increased transferrin receptor expression. So remember that pseudo-palisading necrosis that I showed you? That's exactly what we're seeing here. The brown staining is staining for the transferrin receptor, and those are all the tumor cells. The other thing that has been demonstrated, just like in other malignancies, the higher the transferrin receptor expression, the higher the tumor grade, the more aggressive the cancer is. And outcomes. So the higher the transferrin receptor, the poorer the outcome. And so this was first shown in breast cancer, lymphoma, other malignancies. It has now been demonstrated in glioblastoma. So we decided to take a look at this a little bit closer. And when I say we, it is a collective we, it's not me. And so this really started with Dr. Chris Chitambar, who is a medical oncologist. And he spent much of his clinical career in the breast cancer world, but he's always been studying iron in the background. And he was actually looking at lymphoma. He was trying to find a brain model. And he kind of crossed paths with Dr. Kathleen Schmenda, who I work with closely in advanced MRI imaging for brain tumors. And she and him struck up this hallway conversation. So it's so important to be in those hallways chatting and sharing ideas. And the thought was like, well, why don't we look at glioblastoma? And so this is some of the work that was done here at MCW. And what was shown is also, like we know, glioblastoma in that upper left-hand corner, those cells have increased increased transferrin receptors. But we also looked at ribonucleotide reductase, and glioblastoma has increased expression of that. And then in the upper right-hand corner, you have ferritin. And you can see a nice demarcation between the glioblastoma tumor and normal brain, and that upregulation of ferritin as well. So again, emphasizing that iron metabolism is just as important in glioblastoma. So taking a little aside, I recognize you guys are not all neuro-oncologists, and so you may be thinking about what other roles iron may have in neurologic disorders. And it has been shown that there's excess iron accumulation in many neurodegenerative processes, including Alzheimer's disease and Parkinson's disease. But there's one that should come to mind, and I always try to put one nugget in for residents. Like, you don't need to know that iron and glioblastoma has anything. That's not to be on your boards or write exam. But this one you should know. So this is, there's a set of disorders called neurodegeneration with brain iron accumulation. There's about 10 disorders. There's known mutations. The most common is PCAN, and that is leads to iron being deposited within the basal ganglia. And what you see there is the eye of the tiger MRI. And so that commonly shows up on write exams and boards. And this should just be a pure, easy answer for you. So if residents remember one thing from me, think of this scan. These patients, because of the deposition, will develop movement disorders, especially dystonia, at a very young age. But there's actually iron deposition throughout the brain, and that leads to the cognitive changes and dementia type picture. So take-home points regarding iron. Iron is essential for all cellular processes. We cannot survive without iron. There's many malignancies that will upregulate iron, which correlates to aggressive outcomes and behaviors. And glioblastoma also falls under this category and has increased upregulation of the transferrin receptors and increased iron stores relative to normal brain tissue. All right, so gallium. Gallium, again, that first one that filled in the table, I think it's one of the coolest elements for people who are science geeks. So here's gallium. It is found in the Earth's core. You can extract it from aluminum and zinc ores, but probably one of the coolest properties of gallium is that it has a melting point of 85.58 degrees. So what does that really mean? Well, it means that it's a solid at room temperature. And this is actually a tube of gallium. So those who are actually here in person, you can play with this. You can get gallium online, like Amazon. I mean, because what can't you get on Amazon? But if anyone has hot hands, I don't know if anyone has hot hands. Otherwise, I can put it in water. But if you warm it up enough, it actually will melt. And so that's my hand there. You're able to melt it. It has this viscosity that's kind of thick. I've been told it's similar to like the old mercury thermometers. I've never played with those, but anyone who has, you break it and it kind of rolls around. It's safe to touch though. So, you can't touch that. But I do have hot water here. So I'll throw it in there. And at the end, you guys can come up and see. It's really cool. Don't let me forget. So for anyone who has kids who are like science geeks, just go to Amazon and buy some gallium. It's a fun whole day process. The other thing is, this led to what I call tea time. Because again, those scientists back in the 1800s, they had everything figured out. And so they had time for tea. I don't know how many have had tea lately and sat around with their colleagues, but they like to play tricks on each other. And so this is actually a book. And again, I brought this if people want to like look at it. It's called The Disappearing Spoon. And it basically talks about all the elements, not all the elements, but it talks about all these tales about the elements in these different stories. And so the story goes that a scientist had his buddies over for tea, and he would give them a spoon to stir in their sugar, and they'd all be sitting around, and of course they'd all be in on one guy, and he'd stir his sugar in and he'd pull his spoon out and it'd be gone. And they would all be chuckling and just kind of laughing, like oh my gosh, the spoon, what did you do? What's in your tea? Well, this is a spoon made out of gallium, and because it melts at 85 degrees, it melts into the bottom. And so if you want to, April Fool's Day, you want to play some tricks on your colleagues, you can go make yourself a gallium spoon. But it's really an interesting book. My daughter, 15, read it and really enjoyed it. So for the science geeks out there. All right, what does gallium have to do with iron? So why am I even talking about gallium? Well, let's look at this periodic table again. Gallium's located there. Iron is just down the row. And what did we say about rows? Rows, the elements within a row have similar physical properties. And we know that between gallium and iron. We know that it binds transferrin, it binds ferritin, it binds lactoferritin. It's actually incorporated into cells through the transferrin receptors. But because it's located in the column, a different column than iron, it does not participate in the redox reactions that iron does. So it's incorporated into the cells, but it doesn't participate in those reactions. So you start to wonder if, iron and its role in cancer and malignancy, is there some way that gallium can be kind of fooled? And that's exactly what happens. So it sort of leads into this Trojan horse phenomenon. You have cancer there saying, give me more iron, and upregulating its transferrin receptors. And here you got gallium that's attached to transferrin and saying, it kind of gets snuck in and the cancer cell doesn't realize that. Question is, does this have any clinical relevance? Does it make any difference within these cancer cells? So the use of gallium in medicine is not new. In the early to mid 1900s, scientists were really looking at a way to try to diagnose cancer. And that led to one of the first kind of nuclear medicine studies was actually using radioactive gallium, radioactively labeled. And what scientists found, you injected it, you had a washout period, and when you scanned them, you were left with this sort of scan that shows all these enlarged lymph nodes. Now, they didn't understand why, but it was really state of the art at that time at being able to diagnose someone with cancer. And then not only was it diagnostic, it became a way to actually assess for therapeutic response. So this patient in the upper right-hand corner has lymphoma that now involves the brain, and then received radiation, and it was gone afterwards. So this was published in 1975. And this had two purposes. One is you can use the gallium scan to assess for treatment response, but the other is that gallium is absorbed in the brain. So it's interesting. Makes it an interesting learning point. Gallium scans are not commonly done here because they've sort of moved on to that next generation of nuclear medicine studies. But there are many places around the world that still do gallium scans to assess for cancer, particularly in non-Hodgkin's lymphoma. Gallium then started being looked at from a therapeutic perspective. It is used for hypercalcemia malignancy, which I'm not going to touch upon. But I wanted to highlight really one of the more novel new things is in the antimicrobial world. So this here is galbofloxacin. So drug-resistant or drug-resistant bacteria is really a big challenge that we're facing. Galbofloxacin is essentially Cipro with a unit of gallium there in the aqua green. And what this does is it, again, hijacks that principle that cells that are rapidly dividing, rapidly turning over, need more iron. And that's exactly what bacteria do. And so this gallium molecule, by putting it on the cypro, actually sneaks it into the bacteria, and the cypro in theory works. And they've actually shown this in animal studies. And so they took Staph aureus resistant bacteria, or excuse me, cypro resistant Staph aureus, gave half the animals cypro, half of them galofloxacin, and the group with galofloxacin did extremely better. So this is coming down the pipeline. But again, I'm a neuro-oncologist, so we got to talk about anti-neoplastic properties. So the first drug that was looked at for anti-neoplastic properties is actually gallium nitrate. It was studied in several phase 2 clinical trials looking at solid organ cancers, no brain cancers. And it seemed to have a particular response with bladder as well as non-Hodgkin's lymphoma. Now, these are patients who had no other treatment options. They had really exhausted everything that was available. And these patients actually had significant responses to gallium nitrate. The other really important thing was that it was determined to be really safe. There was no myelosuppressive issues. A lot of these patients had bone marrow that had been really exhausted from all their prior chemotherapeutic agents. The biggest challenge was it required an IV infusion, and that had to be continuous over 5 to 7 days. So the patients would receive a bolus of gallium nitrate, and then they would have to be in the hospital. So it just was cumbersome, and it just really impacted quality of life. And so, scientists sort of stepped back and said, well, is there a way we can make this into an oral formulation? And that's what leads to gallium maltolate. So maltol is a sugar group, and so that's gallium with 3 sugar groups. And the idea behind this really came from iron maltol. So iron maltol is used in Europe to treat iron deficiency anemia, and it's known that it is absorbed. Those sugar molecules that are attached to it help it be absorbed in the intestines, in the enterocyte. And there's these apical transporters that will bind that unit. So the thought is that gallium maltolate probably is absorbed in the intestines. We don't know for sure, but given the similar properties, it's really our best guess. Gallium maltolate has been given to human subjects, and we have seen, this is one of the first published cases. This is a patient with hepatocellular carcinoma. In 1 month later, after taking gallium maltolate orally, you can see that tumor is starting to break up. They actually were able to measure blood levels of gallium as well. So we know that it's being absorbed, and we know that it has potential therapeutic implications. This led to a phase 1 gallium maltolate study in solid cancers that were refractory, so similar to the gallium nitrate study. 54 patients were looked at. There was dose escalation up to 500 milligrams a day. And what you can see is that the toxicity profile is actually really favorable. There was no grade 4 toxicities and really minimal grade 3. You would sometimes see calcium levels drop, hence why it's used in hypercalcemia malignancy. You would also see iron levels that would decrease, maybe mild anemia, but nothing critical, nothing to the point that these patients need to be transfused. The challenge is the company that was making gallium maltolate was also focused on another drug, and that drug didn't really pan out. So that company went belly up, and with that went gallium maltolate. And so these studies really didn't go any further in treatment of solid cancers throughout the body. What about brain tumors? So gallium maltolate really kind of was put to the wayside. But you start to wonder, and this really gets to the work that was done here at MCW in Dr. Shitambar's lab with Mona Alaguzwi, who looked at gallium maltolate in cell cultures. So what they took is they took the 2 glioblastoma cell lines, the D54, U87. These are human glioblastoma cell lines, and combined it, also looked at a rat glioblastoma cell line. And what you can see is that those 3 cell lines had significant reduction in the growth rate of glioblastoma. The control was actually looking at brain microvascular endothelial cells, our normal cells. And that's that flat line on top. So our normal brain cells were not impacted, but the glioblastoma cells were. The next step is they actually looked at 3D cultures. So in collaboration with Dr. John Kuo, a neurosurgeon who had a glioblastoma cell line, these are neural spheres, so they're sort of suspended, and so you get this 3D model. And when you see there is the control, and when you exposed it to gallium maltolate, you can see that there's reduction in that growth rate. Kind of a little flashback into the wine world. If you zoom in on these little microspheres, they look like little clusters of grapes. So wine is still important here. That's all great in vitro. I think we've all seen things that work in vitro, but they never really go anywhere. So we felt the next step was starting to look at the animal model. And so we here at MCW took that U87 glioblastoma cell line and implanted it in rats. And we implanted it directly in the brain, not under the skin. It was directly in the brain. And it takes about 8 to 10 days for that tumor to establish itself. So these animals would undergo MRI to confirm the tumor. And then half of them received gallium maltolate through IV. These are animals. And then we had the saline control. And then they were harvested a couple weeks later. And what this showed, this here is the control. What you have is the initial MRI on day 8 and that tumor that blossomed 2 weeks later. The color maps are actually the MR perfusion. So this is based on the work that Dr. Shmenda does in her advanced MRI research. And the green, the yellow, the red is hypervascularity. And this is common in our glioblastoma patients. Our human patients have these scans done all the time. And this is an example of a rat that received the gallium maltolate infusion. And what you can see is that the growth rate was impeded and the amount of hypervascularity was actually reduced. And this was statistically significant across the animals, in that gallium maltolate seemed to impede that tumor growth. Now, this was IV. So, we still get back to this oral, sort of conundrum. And one of the things is, well, how do you get a rat to take gallium maltolate? You can't just give them a pill. Well, after pondering and much sort of esteemed scientific rationale, it was determined that rats like Nutella. They actually really love Nutella, and you can train a rat to eat Nutella. And so, you would implant the tumor, you would train the rat to eat Nutella, you would establish the tumor was there, and then you would start giving them Nutella with gallium maltolate, and they continued to enjoy it and were quite happy. And so that became our vehicle of transfer. So either the success of these slides I'm going to show you is because it got gallium maltolate, or it's Nutella and we all should be eating Nutella. You can go order that on Amazon too, I'm sure. So what did we see? We saw that the animals that consumed gallium maltolate lived longer, and the growth rate was much slower. So the gallium treated rats are in the orange line there. And the survival benefit was 23 days. So animals that received gallium maltolate lived 23 days longer than control. But what is 23 days like in a rat world? Like, what does that mean? Like, how does that, correlate to human outcomes? And there's actually models out there that say 1 month of survival in a rat correlates to 3 years in humans. So, I mean, that's significant. Now, I don't, it's a model. I don't know if that's what we're going to see in humans, but, my point is that this survival benefit in the animal model is really significant. And I have to share, one particular subject. So this was an animal that you can see the day 43 scan. It looks like a really large tumor in that area. But the animal was actually looking quite healthy. It was looking good. It wasn't having neurologic symptoms. And so we sort of kept feeding it gallium. And 1 week later, suddenly this area was completely gone. And when this animal was harvested and we looked under the microscope, there was no tumor in that slide. And this leads to a phenomenon that we commonly see in our human subjects. There's something called pseudoprogression. And so for patients that we treat for glioblastoma, sometimes their scans get worse, but they actually are doing well clinically. And then that worsening actually subsides. And what that is as the tumor cells are dying, there's this huge inflammatory response, and it's actually a good thing. Pseudoprogression is a good thing. Patients who have pseudoprogression live longer. And so we think this animal may represent a pseudoprogression phenomenon. So we were quite happy with these results at the bench with these, the in vitro studies as well as the animal studies. COVID then hit, so nothing happened, right? We were able to reproduce those animals models, but it was time to start to move it into the clinical world. And so from bench to bedside, I mean, I think this is translational research. This is like such a great example of translational research across the board, multiple disciplines involved. And this is where we are now. So anyone who's done drug development knows that it takes years and years and years, and we still have a ways to go. But we now have opened up the phase 1 clinical trial. And so we now have human subjects. This is the first human subjects with glioblastoma to receive gallium multilate. So this trial is open here. Dr. Chitambar and I are PI on the study, and gallium multilate, all we kept seeing was GA and MA, and that made us think of gamma. And so all these trials, they need like a cute name, right? They need, people get lots and lots of money for coming up with these cute names. So we called it the gamma trial. And of course, the gamma grape is purple. And it really comes in a region in France, in Beaujolais, which is just south of Burgundy. For those who are kind of new to wine, outside of the United States, wine is named by region, not by grape. So the gamay grape is the Beaujolais. And this is related to the Pinot Noir. So it's a young grape. So it has like the strawberries and cantaloupe and lilac fragrances. But if you let it age, so the good ones, you'll pull out these like sour cherry notes and lead pencil shavings and those sort of things. So anyone who's interested in like tasting, pick up a bottle. You can find them everywhere. But back to the study. So this is a standard phase 1 study. We're looking at maximum tolerated dose, looking at the side effect profile. But of course, we're looking to see how the tumor responds and how well patients do, because why would we not? It's part of the interest. This is the dosing. We started with 500 milligrams because it was shown in the previous phase 1 in other cancers to be safe. That is the pills. I did not pick the color of them, but they are purple. And so that's what the company who formulated it came up with. It has to be taken daily on an empty stomach and 2 hours after meals. We just don't know yet about how it interacts with food. Any patient with a prior histologic diagnosis of glioblastoma is eligible, but also molecular GBM. So that earlier part where I talked about this new group of histologically lower grades, but molecular GBM are also included. Monitoring again side effects, but we're also looking at blood levels of iron and measuring gallium levels to again confirm that it's being absorbed. So in conclusion, glioblastoma remains an aggressive, incurable disease. We are hoping that we are going to start changing that curve. We know that aggressive cancers, including glioblastoma, upregulate iron, but gallium can mimic that and can alter that. And gallium multilate has shown promise in the preclinical animal world, and we're hoping to see the same thing in our human study. So this is my team. This is very much a team approach. This study was really done based on the basic lab work of Dr. Chitambar and Dr. Shenanda's lab. But really everyone here, this is a team effort with getting the protocol written, getting patients enrolled, monitoring patients as well. So I'm fortunate just to be surrounded by intelligent, bright colleagues who are also a lot of fun to be around too. So I have to acknowledge a Strain for the Brain, Chasing Chad. They helped fund some of the initial animal studies. These are patient organized fundraising groups. So these patients and families that come back to support it really have made a pivotal difference in getting the basic science done. And then IQAI, Nacella Foundation, and MCW Freighter Cancer Center further supporting the trial. So disappearing spoon, disappearing cancer. There is truly a connection between these heavy metals, and hopefully we're going to see something in the next phase 1 study. So thank you guys for coming. I'll open it up for questions.
You're going to show us the gallium?
Oh, thank you. I totally forgot. Yeah, so now it's totally liquid. So it's been sitting in my tea. So if anyone wants to come up and play, feel free.
If you fed the rats the gallium with food,
yep.
Why not do that with people?
Definitely thought about that. I guess trying
Nutella,
to,
maybe?
Yeah, maybe Nutella. They have to take it with Nutella. I think that trying to make things clean and eliminate any potential confounders was what we thought about with the protocol. But yeah, we did think about that. Yes.
Hi, Max's postdoc. My question is, why gallium? Why not one of those other metals on that same row, nickel, cobalt, whatever? Why gallium?
I think that the gallium is what was being looked at already, and my guess is it has to do with toxicity, some of those other metals, and how that interacts. I wasn't involved with the earliest studies looking at gallium. I think because it was used as a nucleotide in the nuclear medicine study, it's been just sort of a favorite and deemed, safe with humans.
Do you anticipate the gallium being used for newly diagnosed GBM patients?
That would be awesome. So, like all drug studies in cancer, you always start with the recurrent population because, there's risk with doing studies. There's the unknowns, but these patients don't have any other options. But I think certainly if it shows promise, the next step after the phase 1 is moving it to a phase 2, which we're already looking at because this stuff takes years to plan. And then looking at other avenues at moving it up to the newly diagnosed for sure.
How does gallium get eliminated from the body?
That's a good question. How's gallium eliminated from the body? I do not know that. Drink more wine.
Yes.
How is the gallium multiply delivered in the cell culture? Just dissolved in PBS, saline?
I believe so. Are there any questions online? All right, 5 minutes to spare. Happy Friday, everyone. Thank you again for coming.
Yeah, dude.
I know, I think we have